Good morning, everyone. It's a privilege to be part of this webinar and share this platform and to get connected with the uh, fellow anesthesiologists all over the globe. The last decade has witnessed an explosive development in the field of ultrasound guided regional anesthesia. But before embarking on our journey, I thought it is prudent to pay tribute to this great innovator and Dr. Vinay, whose pioneering work provided the breakthrough in the field of regional anesthesia. So the anatomy has been already described in detail, but as a ritual, I'll just uh, explain this diagram in brief, this famous diagram of brachial plexus. The brachial plexus is a lattice work formed by nerve roots from C5 through T1. The nerve roots join to form the trunks. The trunk gives rise to divisions. The divisions form the cords, and the cords finally give rise to terminal branches. So in interscalene block, we target the trunks in the interscalene groove. Once the nerve roots exist, they form the trunks which lie one above the other in the groove formed between the anterior scalene muscle and the middle scalene muscle. And then they traverse towards the first rib and they lie with the subclavian artery. So this is the famous article published in 1970 by Vinny, where he described the interscalene block. In 1978, Lagrange et al. Published in British Journal of Anesthesia application of the Doppler ultrasound blood flow detector in supraclavicular brachial plexus block. And this actually started the journey of ultrasound guided regional anesthesia. But it took almost 16 years when a study group from Vienna, spearheaded by Stephen Capral, published their study as ultrasound guided supraclavicular approach for regional anesthesia of brachial plexus anesthesia and analgesia in 1994. And this really paved way for the ultrasound guided regional anesthesia and various blocks. So now with this brief introduction, we'll come to the main topic, the indications for interscalene block. The interscalene block is used for surgeries on shoulder and arm, especially the proximal humerus. The contraindications are patient refusal, contralateral phrenic nerve palsy, contralateral chest injury, severe COPD, contralateral recurrent laryngeal nerve palsy. All these contraindications are due to the involvement of phrenic nerve in the interscalene block, and that leading to hemidiaphragmatic palsy, which is a concern. And of course, INR more than 1.4. This brachial plexus in the interscalene groove lies about 1.5 to 2.5 centimeters beneath the skin. So it is fairly a superficial structure. And for superficial structures, we use high frequency linear probe. As in this picture, you can see it is cleaned, it is draped with sterile, clean dressing. And before starting any block, you should have patient's consent. You should have a crash cart ready and also intralipid in your store. The most important starting point is the ergonomics in ultrasound guided blocks. Ergonomics is nothing but the position of the performer, the patient, and the ultrasound machine in relation to each other. For right interscalene block, the performer is on the ipsilateral side to be blocked, and the machine is on the contralateral side. The working area is also exposed and it is within reach of the performer and it is under vision. And for left-sided interscalene block also, the same protocol is followed. This interscalene block can be given either in supine position or in semi-sitting position or in lateral decubitus position, whichever is convenient to the performer and the patient as well. Needless to say, this is the new normal. One has to follow the universal precautions and guidelines and institutional protocols, as you are very close to the airway while performing these procedures. So this 2D sonography is compared to the cross section of the body. So if we look at the cross section at C7, this is the artistic depiction where you can see the trunks which are sandwiched between the anterior and middle scalene muscle. You can see the transverse process of the vertebra as well. Similar picture is seen on the screen while performing ultrasonography of that area. Now, ultrasonography of this area can be performed in two ways. One, you can place the ultrasound probe in the center of the neck, just below the cricoid cartilage, in the transverse plane, and then slide laterally. So in this position, in the midline, you can see the tracheal rings. Lateral to the tracheal rings, you can see the hypoechoic structure, that is thyroid. Lateral to thyroid, one can see a circular anechoic pulsatile structure which is non-compressible, that is the carotid artery. Lateral to that, one can see irregular anechoic structure which is compressible, that is the internal jugular vein. You can see the tapering end of the sternocleidomastoid. And just beneath the tapering end of the sternocleidomastoid, you can see the anterscalene muscle. And posterolateral to anterscalene muscle is the middle scalene muscle. In between the middle scalene and anterscalene, now you can see the nerve trunks appearing. So this is the upper trunk. And if you refine your scan by either sliding or tilting the probe, which are refining skills, so you can see the nerve trunks appear as they are arranged as sticks stacked one above the other. Now this appearance looks like a traffic signal. So this is also known as a traffic signal sign. So now if we refine our scan, we can see typically this traffic signal sign in between the scalene muscles. Not necessarily in every patient will get to see the traffic signal sign, but in most of the patients we do see. The other method is that we start scanning from the supraclavicular area and then go cephalad. So here again the lighthouse is a vascular structure which is circular, anechoic, pulsatile, and that is the subclavian artery. So you can see the subclavian artery which is pulsatile. Just below the pulsatile subclavian artery, there is a hyperechoic line which represents the first rib. Just below the first rib, there is another hyperechoic line which represents the pleura, which moves along with respiration. And on superolateral aspect of the subclavian artery is the brachial plexus. These are small globular structures which are hypo or anechoic because the connective tissue is less, and they are grouped as they are seen as a bunch of grapes. Now from here, if we start scanning cephalad, keeping the brachial plexus in the center of the screen, this is the tapering end of the sternocleidomastoid, we can see classically the traffic signal sign. So again, from supraclavicular area, we are trying to scan towards the cephalad, and you can see the anterior scalene muscle, the middle scalene muscle here, and in between we see the trunks which are arranged one above the other like traffic signal. So this is the area, this is the target area where our needle should reach, and we have to deposit the drug in the vicinity of this brachial plexus trunks. So now this video will show you the exiting nerve roots. Why it is important? Because nowadays there is more focus on selective nerve root blocks in order to prevent the hemidiaphragmatic palsy or for even pain therapies. So the level of nerve root can be identified by the transverse process of the vertebra. Now C5 transverse process is deficient in the posterior tubercle. It has got anterior tubercle, but there is no posterior tubercle. C6 transverse process has both anterior and posterior tubercle, whereas C7 vertebra is deficient in the anterior tubercle. It has got only posterior tubercle. So depending upon the characteristic of the transverse process of the cervical vertebrae, nerve roots can be identified. So now this is the C5 nerve root, which is exiting. So you can see the C5 nerve root here, which is a rounded hypoechoic structure because the connective tissue is very less. There can be little variations, and sometimes the not necessarily there will be absence of posterior tubercle. So here you can see the C5 nerve root exiting. After C5, you can see the C6 nerve root exiting. You can see the anterior tubercle. You can see the posterior tubercle. And in between, you can see the C6 nerve root emerging. So if you carefully see, this looks like a peak. This is another peak, and the root is arising. So this is also known as sunrise sign. This is the middle meniscus, the middle scalene muscle. And here is the C7 root, which is seen. So this is a C7 root, and this is the posterior tubercle of the C7 vertebra. There is another important structure here, which is pulsatile. This is the vertebral artery. So vertebral artery is very close to C7 nerve root. Here it enters the foramen transversarium, and from here it ascends the cervical vertebrae and joins the vertebral artery on the opposite side to form the basilar artery. So this area is very vascular. There is carotid artery, there is internal jugular vein, and there is vertebral artery. I'll show you the vertebral artery in the next video. So this is the pulsatile vertebral artery, and here is the C7 nerve root, and this is the posterior tubercle of this C7 vertebra. So one has to be very careful while injecting the drug. One has to aspirate repeatedly and inject small aliquots of drug in this area because it is highly vascular. Now, if we take cross section at the C6 level and we compare it with sonoanatomy, you can see the brachial plexus sandwiched between the middle scalene muscle and anterior scalene muscle, and you can see they are stacked one above the other. And if you keep the probe, how our needle should approach, either it can be in plane technique where the needle goes parallel to the footprint of the ultrasound probe. You can see the entire shaft of the needle as well as the tip of the needle. So for all practical purposes, in-plane technique is advocated for almost all the blocks. The other technique is out-of-plane technique, where you can see only the tip of the needle and not the entire shaft of the needle. So the chances of nerve injury are more with this type of needling. So this is in-plane technique of the interscalene block, where the needle is parallel to the footprint of the ultrasound probe, and you can see the entire shaft of the needle as well as the tip of the needle. Once it reaches the brachial plexus and we start the current, you can see the deltoid muscle twitch the anterior fibers, which is the desired endpoint. We are using the dual technique because dual technique helps to prevent the nerve injury. The third important aspect, that is the injection pressure monitoring, we are not using in this particular case, but one should use the device which can measure the injection pressure, and one should check that it does not increase more than 15 centimeters of water. Now here we are reducing the current to 0.5. Once the twitch disappears and we can visualize the needle in close proximity to the brachial plexus, we can start injecting. Once we can start injecting the drug, we see the lateralization of the trunk and good spread of the drug. You need not go to the opposite side of the trunk. The lateralization of the drug is enough for providing good blockade. Now, after injection is complete, here you can see the needle. So after completion, I will try to scan towards the supraclavicular area in order to see the extent of the drug spread. So once the injection is over, now here you can see the drug is surrounding the brachial plexus, even in the supraclavicular area. Now, if you see the vascular structures which are present, You can see the carotid artery. You can see the internal jugular vein. So this area is highly vascular. So one has to be very careful while injecting the drug. Keep aspirating after every 2 to 3 ml of drugs. Give small aliquots of drug while injecting. Now this is in plane technique. Now the next is out of plane technique, where the needle is perpendicular to the probe. Here you can see only the tip of the needle, not in the entire shaft of the needle. You can see the needle entry. You can see small indentation of the trunk. And once we get the desired response and the desired current, we start injecting the drug and we see a good spread of drug around the nerve trunk. But in practice, we definitely advocate in plane technique for any particular block. So how much volume should be given? So now if you scan articles from 2016 to 2020, one comes across about 15 ml of drug is sufficient to give to provide interscalene block. Whether it can be 0.5% bupivacaine or it can be 0.2% ropivacaine or 0.5% ropivacaine. Adjuvants that can be used are dexamethasone, clonidine, dexmedetomidine. Even catheters can be placed with in-plane technique. The only problem with catheter is migration of the catheter in the epidural space or subarachnoid space, or there is easy dislodgement, as fixing of the catheter in this area is very difficult. Complications: infection, hematoma, vascular puncture, local anesthesia toxicity, nerve injury. The specific uh, complications related to this block is total spinal anesthesia, as we are very close to the dural sleeves. Horner syndrome, because the sympathetic chain is close by, and hemidiaphragmatic palsy because phrenic nerve is also very close to the brachial plexus in this particular area, which the blockade of which leads to hemidiaphragmatic palsy. But there is a lot of focus on this hemidiaphragmatic palsy, and a lot of new studies and publications are seen related to phrenic nerve sparing blocks. So this patient was done about 2 days ago. This patient was a young patient posted for arthroscopy surgery. And this patient was given general anesthesia along with interscalene block, 0.2% ropivacaine 15 ml with 30 micrograms of clonidine. Now in this particular video, you can see the diaphragmatic excursion very well in spontaneous breathing just before induction. So you can see the diaphragmatic excursion very well. After 3 hours, once the surgery was over and patient was extubated, there is hardly any movement of the diaphragm. So hemidiaphragmatic palsy is definitely a reality. This patient was asymptomatic. He did not require any oxygen. In most of the patients with hemidiaphragmatic palsy, only reassurance is enough, and in some cases even nasal oxygen is required. But hardly in any cases you require active intervention. So to address this, there are a number of studies which were carried out. This was published in 2018 in British Journal of Anesthesia by Riazi et al. Effect of local anesthetic volume 20 versus 5 ml on efficacy and respiratory consequences. They studied about 40 patients, 20 patients with 20 ml and 20 patients with 5 ml drug. And they found that low volume ultrasound guided interscalene block is associated with fewer respiratory and other complications, and there is no change in the postoperative analgesia for first 24 hours. This was followed by a series of publications. Now, in this particular study, they uh, targeted the C5 nerve root. This Dobby et al. They studied specific C5 nerve root block, and they concluded that this new technique at C5 nerve root proximal to the level of traditional interscalene block is efficacious for shoulder postoperative pain control. The only drawback is that they did not study the phrenic nerve involvement, but they did mention that no patient in their study complained of dyspnea postoperatively. This was an interesting study published in 2016 in British Journal of Anesthesia. So here, Studner et al., they studied the contrast magnetic resonance imaging and compared the tissue distribution, phrenic nerve involvement, and epidural spread in standard versus low volume ultrasound guided interscalene block. And they concluded that the interscalene block, whether it is low volume or high volume, there is definitely epidural spread. And even though there is spread, they concluded that in low volume group, the extent of the spread was very less compared to high volume. Also, the intramuscular spread was much more in high volume, and the phrenic nerve involvement was also much more in high volume compared to low volume interscalene block. Hussein et al. In 2017, they published a meta-analysis, suprascapular and interscalene block for shoulder surgery, and they concluded that suprascapular block is associated with fewer complications, in particularly those patients where there is obesity, sleep apnea, and pulmonary disease. Suprascapular block is equally effective in post-operative period, especially up to 24 hours, and the complication rate is also very less. To substantiate, there was another study which was published in 2019 by Kim et al., where they studied superior trunk block, and they concluded that compared with interscalene block, the superior trunk block provides non-inferior surgical anesthesia and it preserves diaphragmatic function. So it is also an alternative to interscalene block. Now, the quest to identify the actual site or the volume for interscalene block, Shivashanmugam et al., they published a dose finding study in 2020, and they found that the mean volume required for 50% success rate was about 7.4 ml, whereas for 95% success rate, it was about 10.47 milliliters of drug required. So, this block has witnessed a lot of evolution since Vinny introduced it in 1970. So now we are talking about suprascapular block, we are talking about low volume block. Thanks to the advent of ultrasound guided blocks. So in future, I'm quite sure there will be consensus of this actual site of injection as well as the volume of injection. In our institution, Dr. Diwan has also carried out a study which is accepted for publication. So I'll not reveal the actual once the article is out, you will come to know. But in his study also, he has found even 5 ml of drug is also enough to provide adequate blockade. So I think in future we will have a consensus on the site of injection as well as volume of injection for interscalene block. Thank you very much.